Well, good morning. Good morning. Thank you, everyone, and thank you so much for being here on a Saturday. And first of all, I just want to say I'm really thankful for the opportunity to talk to you today. It's truly an honor to be here with all of you and share some time and talk a little bit about Parkinson's disease. And over the next few minutes, maybe half an hour, I'm going to cover quite a bit. It's going to be a large overview about what do we do when we think about someone having Parkinson's, and briefly, what are the treatments and treatment options that we have for patients with Parkinson's disease. Thank you again for the organizers. I'm Adolfo Ramirez. I'm a neurologist, not too far from here at the University of Florida. I've been there for about 10 years, so it's exciting to see some familiar faces. And here are some of my conflict of interest, but none of them are really relevant for today's talk. But what I want to start is to just really, does it really matter? Ask ourselves a question. Does it matter to have the right diagnosis when someone has symptoms that resemble Parkinson's disease? Well, the answer is yes. When we see someone in clinic, we try to be as accurate as we can with the diagnosis, because having an accurate diagnosis allows us to individualize treatment, plan for the future. It helps us to understand the disease and the prognosis, and it also allows us to invite patients to be part of clinical research. It's really important for all of us to continue to work closely with all the doctors to develop new strategies and treatments to be able to find cures for this disease. And the only way for us to do it is if we have an accurate, consistent diagnosis as early as possible. Sometimes it's really hard early in the disease, and when that happens, we tend to rely on other techniques that allow us to be more precise. But Parkinson's disease is one of the most common brain disorders in our times. And Parkinson's is characterized by a few things. Everyone knows that Parkinson's can cause tremor, but surprisingly, tremor may be absent in about 30% of patients with Parkinson's. So if you don't have tremor, then how do you diagnose Parkinson's? Well, what defines Parkinson's disease is the presence of this slowness of movements. What happens in the brain of someone with Parkinson's is that there is a lack of dopamine in some of the parts of the brain that are really important for movement. And when you don't have enough dopamine, you ended up moving quite slowly. The speed, the amplitude, the rhythm of our movements slows down. And as a matter of fact, everything slows down in Parkinson's. Your gastrointestinal tract slows down and gives you some constipation. Processing information quickly also slows down, so it takes a little bit longer to process information. When you walk, you slow down when you walk. Your automatic movements and your responses, your reflexes slow down. So it's a little harder to catch yourself if you lose your balance. All those things are very common. Another thing that slows down is your speech. People speak more softly, they speak slowly. So when you think about Parkinson's, think about this overall sense of slowness. There are other things that are common in Parkinson's that are also related to the lack of dopamine. And that includes stiffness, those muscle stiffness and rigidity. Sometimes shuffling gait, so patients have trouble picking up their feet. They could have also problems with balance. If you are disrupted or if you trip, you may not be able to catch yourself, among some other symptoms that are common in the disease. Parkinson's is now the second most common brain disorder, and it affects approximately 7 million in the world. Just here in the US, it's estimated that about almost 1.5 million people are living with Parkinson's disease. On average, maybe 60,000 people are diagnosed with Parkinson's every year. And that's probably it's probably an underdiagnosis of Parkinson's. There's probably more cases out there. So it's really important to really understand the disease and treat the disease early and find better treatments for it. It's a common public health problem. Now, there's also, just as I mentioned about the tremor, there's this perception that Parkinson's only affects patients as they're getting older. But now we know that Parkinson's really doesn't discriminate. Parkinson's can affect people from different sex, ethnicity, race, socioeconomical backgrounds. A percentage of patients are young. They're diagnosed in their 30s, in their 40s. So everyone could be affected by the disease. And when we start to think about what may be causing Parkinson's, we tend to think about disorders the way that we think about infections. Sometimes we'd like to say, well, if you have pneumonia, it's caused by this bacteria, so the bacteria is causing an infection. When we think about brain disorders, that relationship, that straightforward relationship, may not be there. We're starting to understand that what causes disorders in our brain are likely a combination of different risk factors. So multiple things need to happen, and if they happen just right, and we live long enough, then a disease is triggered. In the case of Parkinson's disease, we suspect that it's a combination of risk factors that are genetic and combined with exposures throughout our lives. In this slide, for example, we know that age is a risk factor for Parkinson's. There may be some genetic predisposition to have Parkinson's. Not everyone that has Parkinson's has a genetic disorder per se. Only about 10 to 20% of the cases of Parkinson's are genetically defined, but we may have genes that increase our risk of Parkinson's. And then we have exposures. We suspect that certain exposures throughout our lives may affect the dopamine system, and if you have the right tendency, that may trigger the disease. There are a bunch of things that we still don't fully understand, but we starting to investigate the effect of changes in our gut microbacteria and how that accounts or relates to Parkinson's. There's some strong correlations with diet and diabetes and certain exposures to like well water or pesticides. And what happens is that those risk factors combine all together and they affect the way that our cells are able to clear abnormal proteins. So these fancy words of alpha-synuclein, lysosomal dysfunction, mitochondrial dysfunctions, the cells start losing their ability to produce energy, and then they can have inflammation within those cells in the brain, leading to neuronal cell death and loss. Dr. Hauser, actually, at the next talk, he's going to talk a little bit more about what we know about this alpha-synuclein, this protein that appears to be really important in Parkinson's. Now, Parkinson's disease has been considered a chemical disease for a long time because almost 60, 70 years ago, when levodopa was discovered and dopamine was replaced on patients with Parkinson's, there was a significant, almost a magical improvement on some of the symptoms. And if you look at the brain of someone with Parkinson's, we can tell that the parts of the brain that are important, that are supposed to have dopamine, are lacking. There's a lack of dopamine in those brains. And as I mentioned early, a variety of symptoms occur with that. So the most common symptoms in Parkinson's are listed here: tremors, stiffness, changes on your speech. The speech tends to get really soft. You can have slowness of movements, which is ultimately what defines Parkinson's, problems with balance, and also trouble with handwriting. The handwriting tends to get very small and messy and effortful. Things take longer and become harder and harder to do. I have a quick video here to show you an example of how the Parkinson's tremor, a classic Parkinsonian tremor, looks like. Maybe we can play the video. Maybe not. And tell me the months of the year backwards from
December, November.
So this is a video of someone that had Parkinson's, actually had a treatment for Parkinson's. He had deep brain stimulation, and in this example, you can see this is a typical Parkinson's tremor where someone has a tremor that when they're not moving their limbs, so what we call a tremor at rest, and has quite a bit of a tremor. And in this gentleman's situation specifically, he was having trouble controlling that tremor with medication, so we actually intervened and implanted an electrode on the opposite side of the brain to help use electricity to disrupt those signals that cause the tremor, and he had some improvement on his tremor. But I really want to mention that Parkinson's disease, although it has been considered for so long a disorder of movement, there is more to it than the symptoms of mobility. And some of these symptoms have been under-recognized and under-treated for a long time, when in reality, some of these symptoms could be really bothersome for our patients. And as you can see on these slides, some of these symptoms affect the gastrointestinal tract, like constipation, excessive drooling. You can have troubles with depression, anxiety, lack of motivation, problems with bladder, problems with memory or dementia, problems with hallucinations. We're talking about erectile dysfunction, excessive sweating, sleep difficulties. All these problems people cannot see, but could be really, really challenging from someone with Parkinson's. And there is an important need to find better treatments, not only to treat the mobility symptoms of Parkinson's, but also to find treatments for the non-motor symptoms of the disease. And in the slide, you can see there's interest in developing new drugs that are affecting other neurotransmitters that we think may be better at helping with some of these non-motor symptoms. Like antidepressants could be particularly useful in cases of anxiety or depression. There are some medications that we can use for memory. There are a few medications that can be used in patients that experience hallucinations, and so on. So Parkinson's disease is no longer just a disorder of movement. It's a disease that affects the entire body, and all multiple systems in our body may be affected by it. Now, when we think about someone having Parkinson's, we rely on the clinical examination to make a diagnosis. To be able to have Parkinson's, you need to have symptoms of Parkinson's. I know it sounds a little redundant, but when you have symptoms that resemble Parkinson's, we call it Parkinsonism. So when someone has Parkinsonism, all it means is that you have symptoms that look like Parkinson's. And I'm repeating myself a couple times, but once again, Parkinson's is defined by slowness, stiffness, rigidity, and tremors. Early in the disease, it may be difficult to ascertain if someone has all these symptoms, especially when the symptoms are mild. If someone is having a mild tremor or is having trouble with mobility and slowness, but let's say they have other problems that may account for it, like back problems, a bad knee, and then the doctors, as doctors, sometimes we're not sure. Well, it is possible that there's some slowness in your gait, but it's also possible that that is related to some back problems or your knee problems. In those instances, or if you have a tremor that is not classic for Parkinson's, there are other techniques that we can use to try to help us with the diagnosis. And you might have heard about some of them. In this example, I have this a picture of a scan that looks for dopamine. So as I said earlier, Parkinson's is characterized by lack of dopamine in the brain. So you can do a test that looks for that. So you're checking for dopamine in the brain. That's not exclusive of Parkinson's. Other conditions that look like Parkinson's may have a lack of dopamine in the brain. But it could be really helpful, as you can see on this example. On one side, you have a normal scan. It's supposed to look like a nice, bright coma. On the patient with Parkinson's, you don't see that normal shape. That could be really helpful to make the diagnosis. More recently, there has been a lot of interest in looking for ways to find that abnormal protein, that alpha-synuclein protein, that accumulates in Parkinson's in other parts of the body. Because if you can demonstrate that someone may have a tremor, but then they also have this abnormal protein in their body, that can help us also to diagnose Parkinson's or Parkinson's-related disorders. And we know that this protein, by the time that you have symptoms of Parkinson's, the disease probably has been going on for some time, and this protein has accumulated in different parts of the body. People have looked at finding that protein in the gut. You can take small samples of the colon, and then there's abnormal protein. You can find it in salivary glands too, and you can find it on the skin. So based on that, so there has been some research looking at, okay, well, maybe we can do a quick skin biopsy, just like when you go to the dermatologist. They take a small sample of your skin, you put it under the microscope, and you look for that abnormal protein. That's a recent test that has been developed that we can use when we are trying to figure out the diagnosis, when we are trying to improve the certainty of having one of these disorders. We can do that test. It's a pretty simple test, takes 5-10 minutes in the clinic, and it allows us to look for that abnormal protein. It does not look for lack of dopamine. It looks for that protein that accumulates in the skin. There's some research as well that is looking at other techniques also using we know that that protein is very important in Parkinson's, and this is not ready for commercial, or it's not ready for prime time in a way, but there are a lot of studies looking at using advanced techniques that allow us to increase and amplify the presence of that protein in the spinal fluid, hopefully in the next few years, maybe in the blood, that we could have a test that is going to help us to also find that protein or look for that protein, not only to make the diagnosis, but to monitor the disease using that protein and amplifying the presence of that protein in the blood. That's probably a little more in the research realm right now. Going back to what I mentioned earlier, the Parkinson's disease, when you think about the other things that may look like Parkinson's, what are the other conditions that may resemble Parkinson's disease that are not? I listed a bunch of them here on this slide. And what it's important to recognize is that these disorders are not as common as Parkinson's disease. And what they have in common is that they have symptoms that resemble Parkinson's disease. They have Parkinsonism. It's not Parkinson's, it looks like Parkinson's. So they have the same symptoms that patients with Parkinson's will have. But what they have is that they have a variety of other symptoms that your doctors can help to tease apart, look for them, and potentially get a better diagnosis or more direct diagnosis. The biggest difference between Parkinson's disease and some of these other conditions is the fact that they don't respond to the treatment the same way that Parkinson's responds to some of our treatments, and it seems like the progression of some of these disorders is faster. I'm listing two of them here. One of them is this disorder called multiple system atrophy. The difference between Parkinson's disease and this disorder is that it progresses a little bit faster. It tends to affect younger individuals, and it also affects other parts of the brain, specifically the part of the brain that's important for balance. So people with this disorder, they have symptoms that look like Parkinson's, but they also have a lot of balance problems, problems with coordination, early falls, and they also developed a lot of problems with the part of our system that's important for blood pressure control, for control of the gastrointestinal tract, and control of the bladder. So when you see someone that has really prominent bladder, bowel problems, passing out spells, balance problems on top of Parkinsonism, you have to consider this disorder. The common thread, again, is that you may look like you have Parkinson's, but we will look for other symptoms, other areas of the brain that may be affected that can lead to a different diagnosis. Another example is this disorder named progressive supranuclear palsy. In this condition, you have slowness, stiffness, you may look like you have Parkinson's, but on top of that, other parts of the brain, kind of like the same, just very similar to the previous one, other parts of the brain are affected, leading to problems with eye movement that we don't see in Parkinson's. You can have problems with balance that are much more prominent than Parkinson's disease, and people start falling relatively early after the diagnosis, have trouble with impulsivity, problems with memory, concentration, and early falls. And I have a quick example. I have a quick video for that. This is a video from one of my colleagues. It was published a couple years ago. It's a video for one of my colleagues at UF, Dr. McFarland, that specializes in this disease. And what you can see on this video is that he's looking for features that are not common in Parkinson's. He's looking for trouble with eye movements. So he is specifically looking at the speed of how the eyes move. He's looking at the amplitude of the eye movements and see if there's limitations with the range of eye movements. He is looking for symptoms of Parkinson's, he's looking at trouble with balance, and he's looking at how these patients move. So all these cues, all these clues help us to make another diagnosis.
Put your left hand down.
I don't want to spend a whole lot of time in this, but there are other forms of atypical Parkinsonism, and what that means is just means that you don't have classic Parkinson's disease. So when you think about the big umbrella of Parkinson's disease and classic Parkinson's disease, when you call something atypical, it means that you have other features that are not commonly seen in Parkinson's. And we typically refer to some of these conditions: multiple system atrophy, PSP, and then there's these other conditions like cortical basal syndrome, where you have symptoms that resemble Parkinson's but are affecting primarily one side of your body. You tend to have other areas of the brain affected, which include problems with language and speech, problems with stiffness, or even a disease that affects your memory very early on. A disease named dementia with Lewy bodies, where people may look like they have Parkinson's, but they're in these diseases specifically, the thinking, the cognitive parts of the brain are affected very early. So to summarize, when you see someone that has symptoms that resemble Parkinson's, we're always looking for some of these other symptoms, affection or problems with other parts of the brain or the body that may guide us to make a different diagnosis and look for a different disease. There are some techniques that we can use. I mentioned a few. There are some newer techniques that we can use to help us to make the diagnosis. But commonly, observation and time could be also very helpful. As I mentioned earlier, the progression of these disorders is different. So over time, when we see patients coming back in clinic, and as new features evolve and develop over time, that could be also very helpful for us to really make the right diagnosis. There's significant overlap between all these disorders. There's significant overlap between Parkinson's disease and some of them, and that's why, especially early, could be a little difficult to make the diagnosis. Now, coming back to Parkinson's, we have established that it's a disorder that affects mobility and affects other symptoms, and we know that the disease tends to progress slowly over time, and now we are actually able to identify some symptoms that may occur early in the disease. By the time that you're diagnosed with Parkinson's, because you have Parkinsonism, we know that the disease has been present for some time, and then the disease tends to progress over time, leading to symptoms that may be more difficult to treat, and new symptoms may appear as the disease continues to progress. Now, it's important that when you start thinking about treatment for the disease, you have to incorporate all the different techniques available. The treatment of Parkinson's is not only taking your pills on time. It's important to incorporate non-pharmacological therapies. It's important to incorporate treatments like pharmacological therapies, and in certain cases, more of advanced procedures. This is a really important slide. When I referred about Parkinson's treatment, I'm referring to a group of individuals, a team of individuals that will help you to achieve the best quality of life and goals managing the disease. It's really encouraging to see the presence of physical therapies, exercise groups, wellness groups here today, because to really treat Parkinson's, you want a team. You want a team that includes social support, nutrition, regular exercise. There are two things that we know that are very likely to slow down the progression of Parkinson's and certainly help with the symptoms significantly, and that is exercise. And the second one is good sleep. So those are two really important elements of treating Parkinson's. But speech therapy, occupational therapy, cognitive exercises, meditations, you need a group of individuals that may help you to manage the symptoms the best you can, not only necessarily with medications. When it comes down to medications, there's a large number of pills that we can use. The best drug that we have available is levodopa, remains the best drug. But there are other medications that are available to treat Parkinson's, and we use those medications based on your specific situation. There's no recipe to treat Parkinson's. The recipe needs to be customized, it needs to be individualized to specific needs. So some patients may benefit from one medication, some patients may benefit from another one. In this example, I listed a bunch of the different compounds that are available, from like dopamine agonists, COMT inhibitors. There are new formulations of levodopa available. We have levodopa control, immediate release, extended release. There is very recently a new drug has been approved that for management of Parkinson's that has longer duration of the disease. And all that is really important, because one of the most common problems that we face as we treat Parkinson's is that as the disease changes over time, the effectiveness of the medication tends to wear off. It's very common that 5 years into the disease, the medications don't last as long as they used to. And when that happens, we're trying to incorporate new treatments, new elements that can help with that. And that's why new drugs are being developed to make the effectiveness of levodopa to last longer. Drugs being developed to add on to levodopa to make it last longer, as these ups and downs start to occur in the progression of the disease. Now, if medications are not enough and you continue to have trouble managing those symptoms, these what we call motor fluctuations. And motor fluctuations refers to the fact that over time, most patients, probably after 10 years, 70% of patients, they will experience some of inconsistent effect of levodopa. That's probably the best word for it. The response to levodopa becomes, or the medications for Parkinson's, becomes really inconsistent. Sometimes it works, sometimes it doesn't work as well. Sometimes it lasts in between doses, sometimes it starts to wear off. And with medications are just not good enough, because there are many factors that account for that, like the amount of food that you're eating, the proteins in your diet, how you felt that day, the lack of sleep, if you're sick or not. There's all these factors that account for that. There are other techniques that can help us to make to make medications last longer and treat those ups and downs that occur in the disease. One of them is deep brain stimulation. With deep brain stimulation, what we do, and this technique has been around for about 30 years, we implant electrodes in the brain, and when you are lacking dopamine because you have Parkinson's, an abnormal signal is sent to different parts of the brain. If we put an electrode deep into the brain and we deliver small amounts of electricity, we can disrupt that abnormal signal. So disrupting that signal that is caused by lack of dopamine may allow us to improve the symptoms. Just like in an example that I showed earlier, we can control the tremors better, we can actually make medications last longer, and we can reduce the symptoms of Parkinson's. Certainly, this is a technique that needs to be considered for patients that are having difficulty managing their symptoms with medications, but there are other factors that need to be considered when you are planning to have this type of intervention. There are other techniques that could be really helpful that are available right now. One of them is focused ultrasound. The difference between using deep brain stimulation and focused ultrasound is that we target the same parts of the brain that we know that are affected in Parkinson's. In one of them, with the DBS, we deliver electricity through an electrode. With focused ultrasound, what we do is that we make a small lesion using ultrasound. It's a procedure where you go into an MRI, and the MRI has a bunch of transducers, and those ultrasound transducers focus all the energy into one point in the brain, making a small thermal lesion. We have been doing this for almost 100 years. The idea of having a small lesion in the brain to help with symptoms has been around for some time, but it used to require open surgery. Now, what is new is that the technology is better. And we can reproduce, we can do the same thing, but now without having to make an incision. It's an invasive procedure because you're still making a lesion, but there's no incisions associated with them, right? There's also new infusion therapies. If taking medications, you take your medications, they don't last, they lose efficacy, there are troubles with the absorption of the medication, making it work consistently, well, you may wonder, well, how about if we bypass that and we deliver the medications through the skin? Well, there are ways to do that, and new therapies have been recently approved to deliver medication under the skin subcutaneously. There are also ways to deliver medications consistently through a percutaneous tube. What that means is that you get a small port, a medical port, through an endoscopy. This is the therapy called duopa, where you attach a small pump that has levodopa liquid, and it's infused through the tube to deliver exactly the amount that you need directly into the gastrointestinal tract. There are other infusions, like these subcutaneous infusions. There are 2 that are currently approved. There's a 3rd one that may be approved relatively soon. And we're still trying to figure out what are the advantages of it, or who are the best candidates for it. Because it sounds great, right, if you deliver the medication in a liquid form under the skin, but it may not completely replace medications, and it certainly, at least in clinical trials, it has been associated with some irritation at the site of the infusion. If you think about it, and you're kind of pushing a medication under the skin, it's very common to have irritation, some nodules under the skin. And we think that these are going to be great complements to the way that we treat patients with Parkinson's, especially for patients that are having ups and downs and unpredictable responses to their medications. I know that it was a really broad overview. I covered a lot about the basics of Parkinson's, but I will be around to take any questions. Thank you so much for your attention.